Well, thank you very much indeed, Anton. Good morning. Very nice to see so many people here today, and I know colleagues are elsewhere. Thank you very much for the invitation. It's an honor that you do me. Anton has not given me any instructions about what to say, but he has given me license to be a little bit provocative and a bit challenging. So I think what I'm going to do, I want to just offer a few reflections on what I think is quite dangerous territory for someone like me. You know, I'm a bureaucrat who doesn't see patients anymore, but I want to talk a bit about clinical decision making and the clinical consultation. And I do think that's quite dangerous territory because I think we all feel we know about that, and we probably all feel we're quite good at it. And probably most people in the room actually are, because you care about these things. But I don't know whether you colleagues will be aware that since I've been in Welsh Government, I've become quite passionate about the principle of co-production, which is a sort of equality of power relations between the NHS and the people we serve, between clinicians and patients. I feel that actually co-production is a pretty fundamental principle. And I suppose my challenge today is, does it run like a golden thread through all our medical education and training? Because I feel it should. Anyway, so let's tell a bit of a story. When I was here last year, I talked a bit about the need often in healthcare to do, it's just as important to do less as to do more. That in Wales we spend about 50% of our overall Welsh Government budget on the NHS. That's about £7.5 billion a year for 3 million people, which funds industrial scale healthcare. But despite that, the NHS resource overall contributes about 10% to overall health outcomes. And we have relatively high rates of chronic conditions and relatively poor clinical outcomes in many of our areas. So you could argue that the NHS resource is not delivering best value for money. And that probably is true, because in part, a lot of what we spend money on is kind of clinical process that doesn't actually directly impact people. And we also know that most of those monies are spent too late, essentially, when people have diseases already, or actually are quite late on in the natural history of their conditions or diseases, and their destiny is already preset and determined, and all the care we offer at great expense affects that rather slightly. So there's increasing evidence across the world that actually it is as important to do less healthcare, to strip out the low-value activity, as it is sometimes to do more. And that is fundamental to the principles of prudent healthcare and value-based medicine, value-based healthcare, where basically we try to avoid doing things that are of low value to individuals and to people. Now, what I also, I think, said last year was actually we have total control of all this. And that's quite encouraging, because the money that we spend is determined by clinical decision-making, generally by doctors. It is doctors who decide when to see someone in a GP surgery, or as opposed to offering a nurse-led appointment or a telephone call. It is up to doctors about referring people to hospital, to admitting people to hospital, whether to see someone in a clinic in hospital, whether to do a certain test, prescribe a certain drug, do a blood test. These are all what the money is used for, and these are all clinical decisions that we make. So I think it is not unreasonable to think about the clinical decision-making process. Now, one thing that I always get when I talk like this about doing less is people say, well, how can I do less? People want me to do more. There is a public perception challenge here, that, you know, there's always the feeling that something can be done, that the latest technology has to be made available. But I would argue that the views and the understanding of the public need to be developed through each individual clinical encounter, through each individual clinical consultation. I think we protect ourselves from fear of complaints, concerns, and litigation through shared decision-making. That actually patients make decisions about their care, we support them in that process, we document those shared decisions, and in a way we are protected. We are not then exposed in the same way as if we just decide what to do to people we see. So, clinical decision-making, I think there are different levels at which to consider clinical decision-making. I'm going to finish off by talking about the individual consultation. But first I want to talk about clinical decision-making that, in a sense, is more about the strategic or the operational level, the service level, decisions that we make which have clinical impact. So at a strategic level, a health board will make decisions sometimes about the provision of services, how services are set up, or a GP practice may make decisions about where it has a branch surgery or how it offers a certain set of pathways of care or how it responds to people. So these decisions are not necessarily always made with patients, but I do fundamentally believe they should be. We're talking increasingly to health boards about working with their populations, so populations understand the challenges around services, so that strategic decisions, which are ultimately clinical decisions, are made with the public fully engaged. These decisions also need to be made with clinical advice as well. And for me, it is completely unacceptable that there could ever be a decision with a clinical impact that would ever be made by a chief executive or a finance director. We must never allow that. So I think there's something about strategic decision-making involving patients and the public, but then there's also something about how we set up our own clinical services. We need really to follow the prudent healthcare principle, the second prudent healthcare principle, which for me is probably the most important. What it says is treat those with the highest need first, but what I interpret that as meaning is provide a proportionate response to need. Don't offer one-size-fits-all response to everyone, irrespective of their clinical need. If you do that, you will under-provide for those with high levels of need, whilst probably over-providing for those with low level of need. So if we receive a referral letter from a GP in a hospital, we then make a clinical decision about what to do with that referral. If we put that referral onto an outpatient waiting list, we've made a decision, and we've offered, perhaps in that case, a one-size-fits-all solution. It seems to me we need to set our services up so we can offer a range of options which enables us to meet need in a more proportionate way. So when we receive a GP referral letter, are there alternative ways of responding to the level of need? Can we simply write a letter back to the GP? Can we email the GP? Can we ring the GP? Can we ring the patient and have a chat with them? Can we send the patient off for some kind of investigation just to provide reassurance? There are alternative ways of providing a proportionate response to need. And if we don't offer those alternative pathways, we've made clinical decisions, or we've set our service up which limits the clinical decisions that we can make. Last week, I opened an ambulatory care emergency conference and heard some brilliant examples of ambulatory care pathways being put in place that prevented people being admitted to hospital. That they were really inspiring, but I was also aware that those pathways were not being consistently offered everywhere. And so in those places where these alternative pathways, which were entirely appropriate to people's need, were not being offered, the clinical decision-making was very limited and people ended up in hospital with all the attendant problems of hospitalization and, of course, the attendant costs as well. Because if you can manage somebody with a certain condition on an ambulatory outpatient basis, rather than them come into hospital, you are going to be offering better value healthcare. Now, some may say, well, it's more work to provide these ambulatory care pathways, but it can't be, can it? because you've stopped someone coming into hospital and you've replaced that with a couple of clinic appointments, that cannot be more work. That has to be less work, but it depends upon how we arrange ourselves. So I suppose I wanted to just make those comments about clinical decision-making at a sort of strategic and a service level, because every time we arrange services, we affect patients' pathways, and ultimately we affect the care that they receive, and sometimes we limit the decisions that are made for them and in their interests. But let's turn perhaps to individual clinical decisions. Now, this book here, I recently met the author of this book, who is an inspirational doctor called Len Noakes. He's actually the Cardiff City Football Club doctor, has been since 1998. He was also professor of biomechanics at Cardiff University, but he's written this book because it tells the father's story of his daughter's death. She had a cardiac arrest soon after graduating from Swansea University with a first-class degree, and then died after a few months in Rookwood. But he says on page 9, I'll get this in early. Many doctors can't communicate, or at least find it difficult to do so. I appreciate that this is a generalization, that some may disagree with me, but as a doctor myself, I feel I'm able to say it. I think the reason is simple. Doctors aren't trained to communicate. Now, you may disagree with that, but this is a very honest book about his experience as a family member. And he says very nice things about lots of the health service. But he does say that and wants to get it in early. So it's not just me that feels we should have reason to reflect collectively on this. I think there's a lot of evidence that we can make poor decisions for patients. And some of the reasons for that are issues with doctors. In this book, this is a book called Risk Savvy, which is all about how to make good decisions, clinical decisions, by someone called Gerd Gigerenzer. This book I was actually asked to read by Mark Drakeford when he was health minister one weekend, so it wiped out a sort of weekend. But in this book, he talks about the SICK syndrome, which explains partly why doctors make poor decisions for patients. And SICK stands for self-defense, illiteracy on risk at an individual level, risk and benefit, and conflicts of interest. Now, I'm not going to say a huge amount about this, but we all, I think, accept that we will do things to patients to protect ourselves, defensive medicine. And although we accept that, it's fundamentally immoral. We should not accept that. I understand why we do. The drivers to make us act in a way that we feel protects us are strong, but defensive medicine fundamentally is immoral. It's in our interests and not in our patients. The confusion about risk and benefit, I think, sometimes will arise from the way clinical trials are presented to us by drug companies, as if the results of a trial are applicable to everyone and we should use that trial to determine treatment for everyone. And sometimes we forget, what does that intervention actually mean to an individual in terms of their likely benefit compared to their possible risk? We do an awful lot of stuff driven by clinical trials, which actually is unlikely to benefit the individual. But we're not clear about that, and we don't explain that to patients. And conflicts of interest can be quite subtle. It could be the type of service we want to offer. Do we enjoy doing this particular procedure? Do we want to build up a waiting list for TAVI or for some other sexy new technique that we've learned? So the SICK syndrome are basically issues relating to doctors. But I think there are also issues in relation to the doctor-patient relationship. Now, the King's Fund describes something called the silent misdiagnosis, which is the failure of us to appreciate a patient's preference for their care. a silent misdiagnosis of patient preference. Patients have a wide range of different preferences for their care, depending upon their personalities, their life experiences, their social and their family circumstances. Some want a lot of care and to be reassured. Many don't. Many patients actually want less care than the doctors would wish to give them or to do to them. And in fact, most doctors want less intervention when they are patients than they do as doctors, interestingly. The solution to a problem isn't always a medical problem either. So there is something about understanding the patient and the patient's preference. And the King's Fund feel this is a really important issue. It is the fundamental problem which shared decision-making tries to address, that we get to know the patient, we understand the patient's preference, we become the supporter, the facilitator to patients, to mentor them in their decision-making. And finally, let's go back to co-production and this issue of power equality between clinician and patient. In normal life circumstances, our health and well-being is better if we have power over our lives, if we have a strong locus of control. And it's the same in healthcare. If people feel they understand and have the power to determine their care, they can potentially self-manage their conditions to some extent and take ownership of their condition and their pathways for care. We need people to be able to have power in our relationships with them. The difficulty, I think, is that we're not always very good at recognizing when patients have very low power. So patients will have low power in relation to us in many different circumstances. If they don't know or understand, if they're scared, if they're not known as people. I've looked after patients in the past, and I've only learnt much later on that they were, the local mayor or previously, some very significant community kind of activist or whatever. They will have low power if they are in pain, if they're hypoxic, if they're on medication. There's no point in talking to someone on a morphine infusion in great detail about their care unless you take account of that fact. They will have low power if they're in unfamiliar circumstances, not at home, if they're lying in bed with their pajamas on and the doctor is standing by the bed. These are all really, really difficult power relation issues. Patients will have low power if they have had to travel to see the doctor rather than the doctor go to them, and if they've had to wait to see the doctor. They will have low power if the doctor sits behind a desk and they're on a lower chair, if the doctor uses language they don't understand, and if there's clear differences of culture and class. We need to be able to recognize these power dynamics. When I go to my local surgery, as I pull up in the car, or walk occasionally, the first thing I see are that the parking spaces nearest to the surgery are labelled Doctor, 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 and full of very nice cars. But that sends a message to me as a patient that actually you don't get a specified parking space. It's okay if you walk further than the doctors. Now, as it happens, I am a doctor, so I steal the parking space. Well, I went to an ENT clinic in Cardiff. I think it was ENT, or was it eyes? ENT, I think it was, with my wife. And there was a laminated sign on the reception desk saying, "Please wait behind the line." So immediately, you step back and you've been told what to do. You've been given an instruction. Sit and wait until you're called, it says in the GP surgery. We don't see these messages that we send to people that subjugates them and puts them in a powerless position. And yet that powerless position makes their own decision-making very difficult. It makes their ownership of their condition and the ability they have to achieve health and well-being really difficult. So I'd encourage you to try and identify those ways of behaving that we've got used to that actually put patients in that position. Now, the Montgomery Judgement, and I'm sure you're all very aware of that, 3 or 4 years ago, 2 or 3 years ago, has made it very clear in law that we all need to explain to patients all of the options for treatment available to them with the risks and benefits. Patients may make the wrong decisions, in our mind. The Mental Capacity Act makes it clear there is an assumption that a patient has capacity and the capacity to make the wrong decision. But we do have to allow that while at the same time balancing that against our responsibility as far as we can to do no harm. But these are different dynamics within a consultation, perhaps than we're used to over the years. The relationship is different. The patient needs to be in charge, and we need to become the mentor or the facilitator. Now, finally, another approach to consultations that I want to mention before I finish is group consultations. Now, I don't know how many of you have any experience of group consultations. I think they've tended to come in a bit more in primary care than in hospital care, but actually there's a strong building evidence base that group consultations produce brilliant outcomes across a wide range of clinical circumstances. So these are perhaps situations where you may get 20 people with maybe a similar condition, maybe type 2 diabetes or high blood pressure or whatever. They all come together. If they need a blood test or blood pressure measurement, they can all have that. And then the doctor comes in or the pharmacist comes in. It doesn't matter which profession it is. The evidence seems to be the same. And you do your consultation with each person in turn. Patients actually really like it. They will even be very happy to have their feet examined and all this in that situation. There's something about social connectedness. There's something about learning from others' interactions. There's something about realizing you're not alone and you're not necessarily the worst. And there's also something about feeling less of a personal victim when you know that others are in the same situation. And actually the evidence again is that people in those situations want less intervention when they've been in a group consultation. Fraser Birrell, who's a rheumatologist in Northumberland, is one of the leaders across the UK in this, and he does it in his rheumatology practice for patients with rheumatoid arthritis. So there's a strong emerging evidence base in terms also of very positive patient-related experience measures and outcome measures from such approaches. And of course, they're highly cost-effective as well. But again, they promote a knowledge and experience and an ability to feel some sense of control of your condition so you can self-manage your condition in future. So I feel co-production is a vital concept. I think the NHS has, and I've been part of this, and I'm as much to blame as you, left people behind very often. I think the pressure of the work now, because of our failing pathways, makes it difficult to behave in this way sometimes. But I do feel we should at least be aware that there is a power dynamic which is very unequal in most cases between us and patients, and that is really damaging to their long-term health and outcomes, for their prospects of good outcomes. So I hope that what I've said is simply a set of personal reflections from where I sit. I've learned a lot since I've been out of clinical practice, bizarrely, but maybe a little bit challenging and thought-provoking as well. So thank you very much for your attention.
So my only brief to Chris was we're ready for a challenge. I think that the challenge has been provided. If there's any burning questions, would you be happy to take a question If there's any burning questions, does anybody want to put their hands up? And we'll bring you a microphone, if we have a microphone. Do we have a microphone? We do.
Thank you. You commented on communication and sick syndrome and the power for the people. The main problem now for NHS Wales is the bed blockers, the social services. It's not related to communication and misdiagnosis. I have patients on my wards need care to go home. We need to empower the community to look after the patients, relatives, carers. That's what we need. We should get the priorities of NHS Wales service right. Thank you.
I welcome the chance to respond. Directors of social services all say to me that the single most powerful driver of the need for adult social care is hospitalization. We are creating social care need by hospitalizing frail elderly people. Unfortunately, we know, and we all know this, that when a frail elderly person comes into hospital, pajama paralysis, they lose muscle bulk, they lose functional independence. The longer their length of stay, the more the damage they suffer. And all of this creates social care need. Social services can never keep up with the rate at which we're creating need by hospitalizing people who will only be harmed by care. In some areas where actually significant investment has gone into pathways for the frail elderly and they've reduced length of stay by, say, a half, the rate of people going back into independent living has significantly increased. So I think the solution lies with us, with these alternative pathways to care that I talked about, and in the way we design our services. At the moment, I feel, and we perform really badly as a country on a lot of the audits that show how we treat the frail elderly. So the fractures and frailty audits from the Royal College of Physicians, we perform poorly, significantly worse than England. On the dementia audit, we've got about the 10 worst hospitals in the UK. So we can do better, but we are creating social care need.